social work and a clinical social worker with a Maylands-based therapeutic counselling service. She's been in private practice for 12 years and works with individuals, couples, adolescents and families. She shares her practice with her husband Jeff, who is a counselling psychologist. She is an allied health provider registered with the Medicare Australia and receives referrals from GPs within her practice area. Kellene is going to be talking with us on why I do what I do as a private practitioner. So we're going to hear what Kellene does. So thank you, Kellene.
Okay, thank you fellow social workers, and thanks for your time today. The size and length of my originally advertised topic has been cut because wrongly I thought I had an hour, so I've pruned it down. And one of the topics I was going to speak on was the eligibility to become a mental health social worker, but there's sheets of paper up here that tell you how to access that on the national website. So now I'm going to be discussing and focusing today on the eligibility for mental health social workers. Today I'm concentrating on evidence-based practices and why I do what I do in private practice. I will finish with my opinion of why we social workers make very good allied health providers, because I would like to encourage more of you to become mental health or clinical social workers, because there's a great deal of need out there and we're damn good at it. So just to start off, from Jim's presentation, I really do agree with what he had to say about crafting an evidence-based practice, and there's many things that he had to say that will feed into what I'm saying. Mine's a short, based, very punchy, quick presentation because of the time constraints. Hopefully there'll be time for questions. So I agree that evidence-based practice really needs to be about what works for clients. This presentation is more about what the Department of Health and Ageing say that we allied health providers need to provide. So, but I don't want you to get the idea that you need to stick with that or that you need to know all of those things before you get started. And my belief is that you engage with your clients, you start where they are, engage with them at their level and their understanding, never just launch into these prescriptive evidence-based ways of working. Build a relationship, and when you find deficits in your own knowledge, that's when you go out and seek knowledge. Of course, you need to have some beforehand, but I think our social work degree sets us up nicely for that. And then never stop learning. Never get to the point where you think you know everything, or that you've seen everything, because I'll tell you, you haven't. Okay, this is not my forte, guys, so here we go. I'm not really going to talk to that. I realise I didn't have my name up there like Jim did, but never mind. So yes, I've been a psychotherapist since 2001. I've been a mental health or clinical social worker since 2007, and that was 2.5 years after I graduated from Curtin University in 2005. Having done a prior study, so you can see that I came into social work and psychotherapy for that matter later in life. In fact, both of my degrees have been done since the age of 40, so between 40 and 60, I suppose. I've been an allied health provider with the Better Access since 2007, a contracted provider to Better Outcomes for Mental Health, which is Mindcare, which is the Perth and Hills GP divisions of practice. I'm an outreach counsellor with the Veterans and Veterans Families Counselling Service, and there are a couple of other pathways of referral that I have as well. And like I said, I'm in practice with my husband Jeff, who's a counselling psychologist, and it works really well. So I'm really going to talk about what somebody else, as in the Department of Health and Ageing, decree as what are evidence-based theories and things that we need to use. So these next two slides are going to be about the eligibility criteria of the services for clients coming into that service of better access for mental health Medicare, or better outcomes for mental health, which is under the GP practices. And now it's all going to be turned up again because Medicare Locals is starting up. So all of these that you will see here in this presentation, both of these programs pretty much dovetail and they follow each other in what they consider as eligible disorders that people who are being referred by GPs, paediatricians, psychiatrists can get a mental health treatment plan or get subsidised counselling. So you'll see that it's quite tight and it's quite prescriptive. I heard somebody else say earlier about how prescriptive it is. However, I want you to know that that's what we social workers are good at doing. Yes, you need to pay attention to what you need to be doing here, and you need to make sure you report that in your reports to your GPs. However, it's also about using our very, very important social work ethics, ways of working. You know, there's not anything in there about crisis intervention or client-centred or strength-based or anything like that, but that's still what we use. So yes, this presentation is really only about, it's an information giving thing so that you can see what private practitioners who are in those systems, those funded systems, need to pay attention to as being evidence-based. Now, there's a description sheet. I ran out of them, but there's a description sheet because some of these disorders and practices I had to look up myself for this presentation, and I still can't pronounce some of them. So, okie dokie. So we begin with chronic psychotic disorders, acute psychotic disorders, bipolar disorder, phobic disorders, dissociative disorders, eating disorders, panic disorders, alcohol use disorders. So when a GP has a client and he or she thinks that they might be suitable for this particular program or either of these programs, they sort of need to fit into this. But as we know, people aren't their diagnosis. I often invite people to take their diagnosis and hang it up on a hook in my consulting room or sit it in a chair next to them so that sometimes we can look beneath that. But to get into the programs, this is what their eligibility is. So general anxiety disorder, post-traumatic stress disorder, mixed anxiety and depression on their own, conduct disorders in children, unexplained somatic complaints, obsessive compulsive disorder, mental disorders not otherwise specified. This is one of these. Urinalysis, is it? Bedwetting, drug use disorders, sleep problems, adjustment disorders. Hyperkinetic disorders is really another term for ADHD or ADD. Now, I can't pronounce this next one's, guys, but it's about weakness and fatigue, schizophrenia, bereavement disorders, and stress disorders. Now, I can tell you now that not everybody comes to see me on a mental health care plan has a diagnosis like this. So it's really up to the GP in many ways, and GPs are getting more training. Now, there's also a list of magic little things called focused psychological strategies, or FPSs, and we've been having a bit of conversation with the CPD, with Anne, and with National a lot now, because once you become an accredited mental health social worker, you need to pay attention to making sure some of your CPD is focused on these. And that is not because of the AASW, although they're following line as they need to protect us. This is coming from Medicare and the Department of Health and Ageing to make sure that we're keeping up with what we need to do. So we need 10 specialised points in this particular area. So it's a range of evidence-based psychological strategies known as FPSs. They have been shown to be effective for a number of psychological disorders and have been approved for use by allied health providers, and they are psychoeducation. Now, there's many different sorts of psychoeducation, but one of the main ones that the first one I ever knew about was the cycle of violence. So it's actually using props and theories and proven theories that somebody else has developed to educate people about their own conditions and to give them information that's punchy and it's there and it's visual and all of those sort of things. So that's the best one I can think of. Motivational interviewing, those of you working with drug alcohol will know that that's one of the main tools, or a good tool for drug and alcohol, because it helps people. It's a range of way of questioning that gets people to hear their own voice saying things and can see the inconsistencies between their thinking and what's actually happening to them. And it's about moving them through the stages of change. But it's very useful for all sorts of things. Cognitive behavioural therapy, a lot of people say it's past its use by date and it's old hat and everything like that. But in all of my time in private practice, and even when I was working in agencies before 2007, because I was doing both part-time, cognitive behavioural therapy is really quite broad, and there's, I'll give you a website you can go to that has lots of information, worksheets and all those sort of things. I never knew that cognitive behavioural therapy had all of those aspects to it. So I still think that it's a real worthy evidence-based practice, and the GPs love it. It's on everything that comes through, CPD. And incidentally, I've probably got about 35 GPs that refer to me from time to time. All of my referrals come through with psychologists. It's when I write the letter to say that their patient has engaged with me that I inform them that I'm a mental health or clinical social worker. None of them have ripped their patients out yet. So,
what's the website you suggested?
I don't have a www in front of it, but if you Google the Centre for Clinical Interventions, you'll find all sorts of really good things there. It's a psychotherapy research and training website, and it's got all sorts of really good evidence-based materials and that you can use. Now, self-instructional training, attention regulation. We go over the page. Relaxation strategies, including guided imagery, deep muscle and infometric relaxation. I didn't know what that was, but I think from Googling it myself the other night, it's something to do with applying stress or stretching or something. It's not something that I'm really familiar with. Controlled breathing, skills training, problem-solving training, anger management, stress management, communication training, social skills training, parenting training, interpersonal, especially for depression. And I didn't put it up there, but they also say narrative therapy, but they put in practice for Indigenous. But I use aspects of narrative therapy across the board. So what I'm actually saying here is that I and other social workers have so many skills, so many lived experience, so much that we know that's not in here but which can be used in here. Today's presentation is about what the government for the funding, what the GPs, anyone that's involved with these government-funded programs, this is what they say are the eligibility for the people coming in, and what those of us that are eligible as allied health providers to see their patients need to do and need to pay attention to. So after every 6 sessions, a short report goes to the GP. These buzzwords are really great for use in that. However, I'm not saying don't know about them. You don't need to know them all to start with, but along the way, like I said, don't stop learning, don't stop growing. Usually what happens, a client comes in and you can feel and see and know where your deficit is. Find out more about it, and that's when I go to workshops. And because I'm married to a psychologist and the APS stuff comes across, I use their workshops as well as I do anything else. I get it from wherever I can get it. That's the last bit about the prescriptive ones, but of course we know that we social workers work in many ways. We're creative, we're innovative, and sometimes we stretch the boundaries of what we can do. And that doesn't, I'm not saying being unethical here, but it's about finding ways to get what the patient or the client needs. That's what we're good at, stretching it. Now, these last 2 slides, and then it's question time, because I think probably we'll hear more about what it is you want to know from question time. In my opinion, why we, mental health or clinical social workers, make excellent allied health providers is, and I heard a lot of that in your presentation as well, and I've just stolen this from the AASW's brochure on what is a mental health social worker. We have a breadth of experience in assessing and working to bring about positive change for people experiencing mental health problems. We have a recovery orientation. A recovery orientation is integral to our work, with an emphasis on building on strength and creating social supports. We work collaboratively with mental health consumers, carers, GPs and other members of mental health teams to resolve psychosocial problems associated with mental health disorders and to improve quality of life. An AASW accredited mental health or clinical social worker, and you're probably saying, why is you keep putting the clinical in there? That's just a kind of, I sit and meet with networks that consist of doctors, psychiatrists, and a huge proportion of psychologists. The clinical just goes down better in those areas. So I'm just upping it. Okay, because they do tend to lump all social workers in the same basket, and there's nothing wrong with that. We're all great, but it's about a way of educating other people that clinical social workers or mental health social workers aren't doing. I don't know, I'm not going to say it because that would degrade any other social worker, and there's no way I'm going to do that. So, accredited mental health social workers have a particular expertise in helping individuals whose mental health difficulties coexist with other problems such as family distress, drug and alcohol abuse, unemployment, disadvantage, disability, poverty and trauma. So, social workers also give priority to knowing about relevant community resources and advocating for consumers' access and expanding resources and services. So we are in the service of human flourishing. Thank you for that. That's excellent. So I think this is what, because I do sit on these networks on a regular basis, and I think this is what sets us apart from other allied health providers. Many other allied health providers work only with the individual and not from the context in which the individual exists. Many other allied health providers don't concern themselves with connecting consumers to available services or advocating or expanding, doing that sort of thing. Now, be warned, in private practice you need to earn enough and see enough clients. This sort of work is unpaid. So that's the jeopardy of that. And I've got a psychologist for a husband who's a business partner, and he looks over my shoulder from time to time and says, "Are you owed the service in clients again?" So he keeps me honest, I guess. But what I'm saying here is I think allied mental health social workers rock. They really do. So that's my presentation. It's short, it's sharp, but 30 minutes. And I just want to quickly say there is a private practice interest group that's just started. It meets here the last Thursday of the month between 7:30 and 9. Now there is an eligibility for that, and that is that you need to be in private practice at least one day a week. And that is so that the private practitioners that come into it aren't just mentoring people who want to get into private practice, but there are some good people on the register. I'm on there as well as others, that if you want to come and talk to somebody who's in private practice, then I guess you pay for supervision like we pay for ours. So that's the end of my presentation. Thank you for that, but with 5 minutes for questions.
Yes.
Yes.
Just something about Medicare locals. Can you explain how that will affect the way you practice?
I can't, because even my division of general practice, which is a Perth Primary Care Network, they don't know how it's going to run yet. They've only just been appointed as one. They're still trying to work out how it's going to work, so I don't know. I just got a letter during the week to say that all contracts are off now, so that means that in a week or so I won't have a contract with them, and they're going to send us through something else where we need to reapply. Now they are going to advertise in the newspapers for anybody else who wants to get in. Now that's Perth Primary Care Network, so, and that's in the hills and districts and Perth areas. I don't know about the others in Cannington and Gosnells and various places like that. So, but these contracts come up from time to time. So I can't tell you about that, sorry. Anything else? Yes.
Someone asked me this the other day and I didn't know how to answer them, so I'll ask you. What if a mental health social worker just wanted to work with people with depression and anxiety and didn't want to go to the heavier end like schizophrenia? Can you pick and choose?
Yes, particularly in private practice. We practice from home. And I have patients or clients that come to me that have got a diagnosis of schizophrenia. I say up front that I will assess and see whether or not it's safe for me. My husband's not always there, and we've got 2 consulting rooms, so he's not always around. And there have been a number of times when I find out that that person's not on their meds or not. The criteria is they need to be working with a psychiatrist and seeing the psychiatrist regularly for medications. So yes, you can pick and choose who you work with.
Can I just speak to that as well, if that's all right, Kellene? I think the other thing is, while there's talking about schizophrenia and psychotic, there's so many people out in the general community now with anxiety and depression. That's the bread and butter stuff that comes in the door on the Kellene, and the cognitive stuff around relaxation and deep breathing, progressive muscle relaxation, all that kind of thing is really practical things that we can teach people to do that are just really important. So, I mean, I work for myself and I do like post-traumatic stress disorder, but that's a specialism that I work in, but I wouldn't see a lot of that
the other
in there
stuff.
at all.
That's why I couldn't
yeah,
pronounce
I
it.
wouldn't feel competent to manage that. So I think it's about finding what your skills are and where your competencies are and stay with that. Because there's a lot of them I wouldn't be able to touch, but I think, yeah.
And that's why I couldn't pronounce it and didn't know what it meant, because yes, I agree. A lot of it, you see the generalised anxiety. I do post-traumatic stress disorder because I work with veterans and Veterans Affairs, and they're pretty good at training me. So like I said, I'll take my training from wherever I can get it. Mixed anxiety and depression, everywhere. Unexplained somatic complaints, obsessive compulsive, which is an anxiety based. So yes, you're right. There's bread and butter things that you see all the time, and then every now and then somebody walks through, and the comorbidity, I've never been able to say that. You see that more and more and more as well. It's never ever cut and dry like this, but it's just the GPs need to write something down like this. I have people that come and see me that have got marital problems. So that fits under stress disorders. Be creative.
Yeah, I've just started this. I'm registered. And what I did, I've registered doing it at home, and I've gone to a Metropolitan Migrant Resource Center, which is dealing with refugees. I feel some of this is medical terms which are being used. But in actual fact, when the client is coming, it won't be all that.
Oh,
you can
no.
manage all. It's just language which is being used there. Directing one-on-one with the client is not all that.
No.
Is when you are dealing with an individual, in most cases, there's something triggering that trauma which is being said. There's something triggering all those things which are being said. And once you solve that something which is triggering, you'll see the change of the patient.
Yes.
This is what I've realized. I've worked with the refugees, and in most cases, this is the case. There's something which is triggering that thing. Once you solve that triggering thing, you're going to treat all this.
Yes, we agree with you. So yes, this presentation, however, was about evidence-based, and so in the time given, it was so that you knew what the eligibilities were all the way along the food chain, I guess. Yes.
Just out of curiosity, because you mentioned psychotic disorders, I heard that somewhere that private psychiatrists can refer as well
Yes,
to that.
they
So
can.
people, if they see somebody privately that manage meds, they don't need to go to the GP. for
No,
referral for this.
I've had clients come straight to me from a psychiatrist,
Yeah, yeah,
and a paediatrician can
they can do as well.
direct as well.
Because they have all their kids on vigil.
Yeah, they're the three.
Yeah.
I work with adolescents and that. Anyone else? Whoops.
I was just going to say to people who are a little bit fazed by some of the diagnoses, that
Yes.
people who attract these diagnoses also have stress and depression and relationship and parenting issues and all of the skills that many of the people in the room already have.
Yes.
And not to be too fazed by those
That.
words.
Yes.
And that's what I said. I said, for goodness sake, don't wrongly think you need to know. Like I said, I don't even know what half of these things mean, but I do it. I know I do it, and most social workers do. But because it's an evidence-based, prove what you're doing kind of thing because of the funding, you need to be aware of them, like you were saying, Jim. Don't think I'm a social worker and I don't need to know about psychiatrics and stuff like that. You need to know how to use a DSM-4. Those kind of things.
ICD-10.
Okay, whatever. Yes. Yep.
We're going to have to finish at this point, but maybe at the end, when we come to a close as well, if you still have more questions for Kellene, you can bail her up then. So can I just again say thank you to Kellene for her presentation.